lunch meeting is put on by the Santa Barbara Neuroscience Institute at Cottage Health System, and it's part of our lunch series. There's no member of this committee and I have not been involved in any industry relationships which would affect the content of this talk, as a disclaimer. What's the purpose of this series? It comes down to sharing our expertise in ways that can be used for all healthcare providers. And that's why I structured the talk I did today. It's primarily for practicing physicians, nurses, healthcare deliverers, residents in training. We have a steering committee at the Neuroscience Institute, which is pretty broad, and it was meant to be broad to foster and facilitate interspecialty dialogue. We put out a magazine 3 times a year, which is, I think, filled with useful information for practitioners in the area. Rather straightforward clinical instruction, and it's a lot of work, but a useful endeavor. We have a yearly neuroscience symposium called Saving the Brain. It's been well attended in past years. This is our 8th year. And this year we're doing it on a Friday instead of a Saturday. We hope that will improve the attendance. If you'd like to think about attending the meeting, speak to Tracy or Gary. You can email Tracy or Gary Milgram. They have all the information. So why pain management? In this talk, I'm not going to talk about the miracles of neurosurgery and all the patients we can make pain-free with procedures. I'm not talking about that group. I'm not talking about invasive pain management. I'm really talking about the management of pain in the hospital and in the office, and what is evidence-based and what is not evidence-based. And I've been practicing in this hospital since 1982, and in those 30-plus years, in the first 12 years, I'd say, I accepted what I was being told about pain management. But even I learned that what I was being told was probably not correct, and that is the use of opiates to treat pain, particularly chronic pain, was, I always thought, flawed, but I kept seeing more and more patients show up in my office year after year after year with stable MRI scans and more pain on more and more opiates. And I began to question, what were we doing? Is this really getting people back to work, getting back people to function at a high level? And the answer to that was no. And so what was wrong with what we were being told? And there's plenty, and we can go into that in greater detail. I think that if you look at the science behind pain management, there's very little, particularly using opiates or injections for pain management. What is the most frequently prescribed medicine in this country? Vicodin. There's more Vicodin prescribed than Simvastatin, which is number 2 in 2010. And I think it was 131 million prescriptions were written in 2010 for Vicodin or Norco, hydrocodone. As a nation, we consume 90% of the world's Vicodin and 80% of the world's opiates. Either we're in a lot of pain or that's inappropriate, and it's probably the latter. And why are we doing that? Because of the medical-industrial complex, leading us by the nose, telling us that opiates are good, and the longer acting and the higher doses are even better. And we bought that argument for many years. And I think it's time to shift the paradigm so that we actually look at the science behind that and ask ourselves, should we be doing this? The answer, I think, is no. But so I'm going to look at pain management through a neurosurgical lens, but we're not going to talk about surgery, except very peripherally. So I don't know what's happened other than. So it turns out that when you're treating pain on the ward or in the office, you're treating this, but what you're actually seeing is the blue, pain behavior. So if you're treating the pain behavior as if it's pure nociception, you're treating the patient inappropriately, because opiates don't control pain behavior. And that's the majority of what you're seeing in front of you. So we've been taught that, oh, let's grade it on 0 to 10 and give fentanyl or Dilaudid or Percocet accordingly. And that's just, I will make the case, not good medicine. So I hope that you're able to learn during this talk that you need to separate anatomically consistent pains from multifocal or diffuse pains. Anatomically consistent pains are, you have a bad knee and you have pain and swelling in your knee. That's pretty obvious. That all fits together. You have sciatica, you have a foot drop, all fits together. But if you have a patient with the whole leg hurts, front, back, side to side, you've got to start asking questions, well, is this a disease entity or is this an elaboration of something else? Is it a centralized pain syndrome? Is it what we call now central sensitization, which is, yes, there's a pain message that went to the brain and it was amplified 100 times there. And to the patient, that's still pain, and it's real pain. But it's inappropriate to treat that same pain the same as if the patient had a bad knee or sciatica. We're bad in the office of taking psychosocial histories in pain patients, but it's absolutely essential in chronic pain. If you're going to treat the patient, you need to understand who the patient is. That means from early life to now. I just saw a woman in my office with chronic back pain over a year. And she had an MRI scan that, like 95% of MRI scans, looked like she was over 65. That means there were some abnormalities there, but I call them normal abnormalities. So what's driving her back pain? She'd already failed pain management. Injections here, injections there. They want to go back and do a facet rhizotomy. She'd already failed 4.5 months of physical therapy, she said. So then, when I started reviewing, well, what's her life story? Turns out she's been the 24/7 caregiver for her dying husband for the last 2 years. And as she's telling me this, she's crying. So you know right away that there's more going on here than just a simple back pain. Well, let's operate on you. You've got to treat the patient. The patient is telling you that stress is a major issue in her life, and she's still in the grieving mode, and that needs to be managed. And that's probably more important than all the other stuff. And it just takes a simple historical few questions to determine that, and not refer her back to pain management. The facet rhizotomy is not going to work for this lady. Opiates are not going to work. Fortunately, she's intolerant to opiates, or she'd be on those. Look in the past history for substance abuse, alcohol, opiates, cocaine, other drugs, because these problems travel in packs. And if the patients have an alcohol history, they probably have a sensitization issue to opiates. You've got to be aware, you've got to be very aware to put that patient on any sort of chronic opiate therapy, because you're dealing with a tiger by the tail, and you're not going to be helping that patient. Doctors primarily use heuristic learning and treat in that fashion, which is trial and error. Very little around us is totally evidence-based. The gold standard is randomized controlled trial, but those are expensive, and as we'll see, they're hard to do in surgical patients. So it turns out that heuristic treatment is very subject to bias, both internal bias and external bias. And we've got pharmaceutical companies with making $3 billion a year off one drug that very much want us to keep using that drug, just like the cigarette manufacturers in the days before cigarettes were said to cause cancer. And they're still going, pushing their wares. But I'll just tell you that I think if you look at the medical literature on opiates, it's full of their fingerprints. They even commented in the small print at the bottom of the pages, they've helped the authors write their papers. And they've paying these people under the table as pain management experts. So beware, heuristic learning is okay, but beware of the biases. So we're going to talk about acute pain It's very important to make an accurate diagnosis. What's the cause? And therefore, if you know the cause, you know the treatment. If you're unclear about the cause, that's okay for a while, but if it's something that's not acting like a regular disease, you've got to start worrying about, is this the opening shot of a chronic pain syndrome? And then you have to go into all the risk factors and manage them in that way. Chronic pain, you absolutely have to take a psychosocial history, and you have to worry about opiate exposure. And we'll talk about that in greater detail. So pain is in the bottom line is it's a product of the brain. Even Einstein, and that's his brain in a bottle. The 10-point scale is a dangerous tool when used in a clinical vacuum, is my take-home method. The 10-point scale is one of the worst things they can do to nursing, physician care, and hospital patient care in my experience. It's simplified, it's idiotic, and it should be used as an adjunct, but not the mainstay of deciding what we do to what patient. We checked our brain at the door and said, well, the pain scale said 8. You know, forget everything else. Like that's enough. And that's just not enough. So yes, these are the simple diagrams that we learned in Physiology 101, college or nursing school or medical school. The C fibers are unmyelinated and carry slow impulses from the area of trauma, maybe more relevant to neuropathic pain. The A delta fibers are myelinated, conduct sharp, sudden pain from a hammer on the foot. There's a cause and effect, you would think, right? That's what we were taught. You hit someone with a hammer on the toe, there's a signal that goes up to the brain, and there's an effect we can grade in a 0 to 10 way, but even that's wrong. The signal actually turns out to be more analog than digital. And that explains the so-called battlefield effect. Soldiers on the battlefield shot through the arm or leg, not even being aware of it. That explains the enhanced pain in the setting of grieving or natural disasters, where emotions are high. So it's all modulated through inserts on the brain on the pain pathways. These are slides I sort of borrowed from Sean Mackey. Sean Mackey is the head of pain management at Stanford. He's an MD, PhD in electrical engineering and spends about 80% of his time in the lab researching chronic pain, and was the last head of the Pain Society. We're trying to get him here to talk, but he's elusive, and so I have yet to hear back from him after several emails. But I think these points are right on. Pain is a product of the brain. It's dependent on our cognition, the context of the pain, individual differences, and mood. So, if we're very attentive to the causes of pain, we're going to have more pain. If we're distracted, we're going to have less pain. If we're hypervigilant, which is a sociopathy, we're going to have more pain. If we're catastrophizing, Chicken Little syndrome, we're certainly going to be more prone to pain. The context. If I believe that I have cancer, and that pain is a symptom of cancer, it's going to grow in my mind, no matter what my doctor tells me. Certainly that's a tendency. If I'm really convinced that that epidural steroid injection is going to help my leg pain, guess what? It does work. And that's called placebo. That's maybe why acupuncture works. That's maybe why chiropractic works. So many of the things we do. That's why many of our surgeries work. I'm not just isolating those other specialties. But if I do a procedure for pain, frequently you hear the doctor say to the patient, well, wait 6 months or wait a year. If you have to wait that long for a procedure to work, then it's probably not going to work. And what advantage you got may have been placebo. Motivation, if the patient is motivated at their job and happy in their work, they're going to get less likely to injure themselves and develop a chronic back pain or neck pain syndrome. Motivation is highly correlated, if it's positive, with less pain. Genetics. Turns out there's some fascinating new information on genetics. There are about 20 to 30 mutations now that correlate with higher or lower pain threshold. There's a fascinating story of the COMT gene on chromosome 23, which depending on whether you have a valine or a methionine, you either act like a warrior or like a worried person. And they found this gene mutation more so in fibromyalgia patients. And so it's fascinating to think that our genes are modulating our pain threshold, but it's true, there's good evidence that this is the case. So there's a single nucleotide polymorphism where a valine replaces methionine or vice versa. And if the valine is substituted, you sort of get a warrior mentality with a lowered, and because you have a higher COMT activity, which is the enzyme, programs for the enzyme that degrades catecholamines, which include norepi, epi, and dopamine. You have lower dopamine levels and you have a higher pain threshold, and yet you have apparently a reduced executive functioning. So the higher pain threshold comes at a price. If you have a methionine substitution, you have lower COMT activity, higher dopamine levels, and lower pain threshold, but enhanced vulnerability to stress, yet improved executive cognitive reactions. So these genetic mutations are just being described, and it's something in progress, but I think it's worth noting that we're being pulled along by our genes more than we thought. In gender, it's clear that females have a different response to pain than males. Maybe it's because they're more verbal. They tend to have more chronic pain than males, but they tend to have a better response to opiates for post-procedural, post-operative pain than males. So there are clear gender differences in chronic pain. Depression, we all know that if someone's depressed, I call it a bidirectional comorbidity. Depression breeds chronic pain, and chronic pain breeds depression. So we have to be aware of depression and treat it. We can't just ignore it. Anxiety, anxious patients who are convinced that you're not finding what they think you should be finding are going to just drive themselves into a chronic pain state. And if there's a high emotional context to the injury, which resulted in the pain, if there's litigation involved, there's going to be a much higher risk of developing chronic pain down the line. So again, mood is a major factor. So it's nice when we're confronted with an acute pain syndrome. STEMI, ST elevation myocardial infarction, is one of those. What if I told you that major studies showed that only 15% of people with STEMI were actually are going on to developing an AMI, and that 85% were either false or some other system, or the leads were placed wrong, or the patient had pericarditis, or they had LDH, or they had some other problem masquerading as ischemia. So it's not always as easy as just looking at an EKG and making a quick diagnosis and responding. Even acute pain, therefore, has some dilemma in a differential diagnosis. If we treat this person with a trip to the cardiac cath lab and do all the fancy things we can do, then 80% of those people may be treated incorrectly. So we've got to try to make a differential diagnosis and try to be astute, but realize we're still going to make errors of commission or omission. And the bottom could be podagra, gout. There could be cellulitis. So the treatments are highly variable, right? So you've got to make the right diagnosis and treat. And with that, the cost of medical care will come down. The patient will do well. If you turn something into a chronic pain problem by confusing the diagnosis, not delivering expeditious care, then you could be pushing patients into chronic pain. Acute low back pain is probably second to headache, the most common thing we see in our office, and is one of the more mismanaged, frankly. Because 95% of acute low back pain is benign. It doesn't even have, even if we do all the scans, we can't determine what's causing it. Fortunately, 90% of it gets better in 6 weeks if we don't even touch it. So the best thing to do with someone who has acute low back pain is to do nothing, except to tell them to be active, take over-the-counter medications. I mean, obviously there's some people with such severe pain, you've got to use prescriptions for a while. And remember, you can't just put your mind on hold and not look for red flags like the night sweats, the fevers, the history of IV drug abuse, the diabetes that might predispose the patient to discitis, history of cancer, maybe metastatic disease. So you've got to look for red flags, but if you've looked for red flags, so I call them, and you find none, and it's just benign, acute low back pain, that's something you should reassure the patient about and not do a scan, not do an x-ray, and if you can, avoid the opiates. So how do we treat acute pain based on evidence-based medicine? Avoid prolonged exposure to habituating drugs such as benzos and opiates. This is one of my favorite pet peeves. Patient has a scan. They go into their physician, and the physician says, "No wonder you hurt. That's the worst back I've seen in 6 years." Or, "Oh God, you've got arthritis everywhere." And the point I'm making is, if you look at the evidence-based medicine to support that, there is no correlation between the degenerative changes on an MRI scan, whether they have bulges, small herniations, set joint arthropathy, mild scoliosis, and pain. So you're telling the patient they're falling apart, and you expect them to feel better after that discussion. So it's better just to recognize what the evidence is, not medicalize them by telling them to make yourself smarter than they, that their back is falling apart. And just reassure them that there's no sign of any active disease such as cancer, infection, fracture, things like that, and just move on. Reassurance is often much more powerful than a drug. Patients come to you for reassurance that whatever pain they're having is not the tip of the iceberg. It's not something around the bend that's going to really be worse. Touching the patient is therapeutic. We don't do enough of that anymore. Nurses are compromised because they're at the computer by dictate. Physicians are ordering scans and not examining patients. They're not talking to patients about their past medical history, unless they're an R1. It's terrible because it's not doing the patient any service. The history and physical exam are far more important than any imaging studies, usually. And obviously there's the wow factor of finding a cancer that no one expected or an infection no one thought about, but 9 times out of 10, I'll take the history and physical exam over rush to imaging. And it will be a much cheaper world to live in and much better for the patient. You have to understand your patient. These are 2 different pain diagrams. One on the left looks like typical sciatica. One on the right, I don't know what that is, but it's nothing anatomically consistent. So it raises the concerns of some other disease process that's associated with the central sensitization process, a functional overlay, we used to call it. So you have to worry when you see this pain diagram, what else is going on in this patient? Then you go into your review of systems, how was your childhood? Oh, I was from my family broke up. Why? Oh, my father used to beat me. You find that in your history with a patient. There's a very high correlation between early childhood upsets like that, alcoholic parents, child abuse, broken homes, and later life chronic pain. I'm not saying everyone has it, but that's a red flag. So you have to go into the history. Ongoing issues with financial, marital, and job stress. Doc, I hate my job. And by the way, I'm disabled by back pain. You're never going to make that person whole, so you better forget the scalpel. So in the long and short of it is this is more like putting a complicated puzzle together, not taking a snapshot. And it does take some time, and we're not being reimbursed for that time, but it's still better medicine. And I know that the hospital nurses are in the worst position of all because the patient's dropped in their bed, they don't know the patient, they don't have time to get to know them frequently, they've maybe already had a procedure, and it's very, very difficult to figure that out. The recovery room is an even worse scenario maybe because they just come freshly out of surgery or emerging from anesthesia, and that's altogether extremely complex environment to be able to monitor someone's pain and treat it effectively. Basically, if you're treating both of these patients the same, you're treating with a blunt cudgel, and you should be treating with a scalpel. That is, you should be dissecting out the nuances. Is this a clinical syndrome, or is this some atypical pain problem that has a chronic pain connotation that needs to be treated differently? What is chronic pain? It's any pain lasting over 3 months, but it's also, the asterisk is any pain that lasts beyond normal tissue healing for that body part. So a lumbar disc is an avascular structure, may take longer to heal than the face, certainly. So you might give that patient 6 months. Some doctors would give them a year to get over an acute low back event. It's very common. Depending on what you read, either a third of adults or 30 million people in this country have chronic pain in some form. So one of the risk factors for chronic pain, as we discussed, early life emotional trauma has a high correlation with later life chronic pain. It changes the brain in an immutable way that predisposes that patient to developing chronic pain. We'll talk more about that. History of depression, much higher linkage between depression and chronic pain. And as I said before, it's a bidirectional comorbidity. One feeds the other. History of anxiety. Fairly high incidence of people with chronic anxiety, particularly chronic anxiety, depression syndromes with chronic pain. Social turmoil, job dissatisfaction. These are all things you need to address in the history. And it doesn't take long to address them. Gender. Females, for whatever reason, have a higher incidence of chronic pain. Fibromyalgia is one of them. So there's a clear gender difference. Maybe because men are too stupid to complain, I don't know. Opiates. Opiates, previous exposure on a long-term basis with opiates predisposes, and we'll talk about this further too. And this is what I didn't know. This was the aha moment when I finally figured out what I was seeing over 30 years and why patients were getting worse every week or every year I saw them without any deterioration in their physical exam or MRI. And I'll go into that. So here's how most physicians practice. It's called heuristic. Trial and error. Just like the ladybug, we bump into a lot of walls before we find the target. And that's all said, that's good. I mean, Alexander Fleming benefited by that approach when he discovered the bacteria were not growing around these molds, and that led to the discovery of penicillin. But it's subject to incredible bias, internal biases and external biases. And we have to realize that and be very suspicious. The placebo effect. This was published in the New England Journal. In a study, they found a 58% incidence of placebo effect in sham surgery. That's pretty disturbing. If you have an operation you're doing that's only helping 60% of the people, you shouldn't be doing it, unless it's life-threatening problems. If we send a person down the road for an epidural, does that mean, and they get better for 3 weeks, does that mean we should be doing it again? Or should have done it in the first place? And we'll talk about that. But we have to be able to question ourselves in order to develop some suspicion that, hey, this isn't evidence-based. You know, no one's done an RCT on this, or if it is, I haven't read it, and maybe we should be suspicious. If it's expensive, invasive, I wouldn't normally do things that I suspect are placebo. But I do plenty of placebo treatments if it's not expensive or invasive. So the RCT is the gold standard, right? Where we randomize people to one group over another and see what comes out the other end, and we can compare them, and we can be pretty sure if the RCT was done well, we can take that answer to the bank. The problem is RCTs are very expensive, and they're hard to do in surgical patients, because how do you convince a patient to undergo sham surgery? They've done sham surgery RCTs. They did one on the heart. People were doing a procedure thought to improve blood flow to the ischemic heart, and it was quite the rage 40 years ago. And then finally someone did an RCT where they did a sham group, and it was debunked. You know, gastric freezing was another thing that was done, and that was debunked by an RCT. Washing out the degenerative knee joint was partially debunked by an RCT, although you talk to orthopedic surgeons, and they'll say, well, there's subsets of that group that they still would do it on. So what is it about opiates, that's bad? First of all, we all know opiates do a lot of good. They've been around for a long time, I think thousands of years, in fact, from the poppy plant. And then in 1806, the ability to synthesize organic compounds that were similar to heroin made them more available. In the 1940s, the federal government clamped down on the availability of these drugs because they're recognized as being dangerous. However, in the last 40 years, it's been an exponential growth in the use of opiates. If a little's good, a lot is better. That seems to be what we do in American medicine. Yes, there are many different opiate receptors, including some I didn't put up here. The main one you need to remember is the mu receptor, which is the real receptor that the morphine compounds work on. And they're scattered throughout the thalamus, cerebral cortex, basal ganglia. And there's a genetic difference in the density of these receptors, it turns out. And if you have more receptors, you have more pain tolerance. You have a higher pain threshold. If you have fewer, you have a lower pain threshold. And no one knows how many they have, but that's been worked out in animals. Obviously, it's hard to do it in humans. They're highly concentrated in the nucleus accumbens, which is in the forebrain, and is the one so-called pleasure center. Mice lacking mu receptors are more sensitive to pain and do not become morphine dependent. But what are the downsides of opiates? We'll get into those, but here are some of the side effects we all know. Impaired cognition, depression, something called opiate-induced bowel disease, GERD, unexplained urinary retention, sleep apnea aggravation, and something I wasn't really aware of, dry mouth resulting in increased decay. These are the things that until I started reading about opiates I didn't know about. Low cortisol. It turns out that opiates block the pituitary adrenal axis. Some people are clinically hypocortisolemic, and that needs to be recognized when someone on long-term opiates is admitted to the hospital. They may need steroid support. Osteoporosis, I wasn't really aware of that, but it's an effect of opiates. Low T and low gonadotropins. Now, pain management doctors are clued into this. They put a lot of their patients on testosterone. But if you've got someone with a low T walking around that's 35 years old, you probably should know about it because they're going to have some symptoms. Methadone-related long QT interval and sudden death. There's a higher risk of sudden death in methadone patients than any other opiate, even though methadone has some advantages in that it's a NMDA antagonist and therefore is thought to be a little safer to use long term. We can quibble with that, but in any event, that's the party line. Impaired immune response. Turns out that both humoral and cellular immunity is affected by opiates, and it's thought to be one reason why heroin addicts are so prone to infections, and why it may even predispose to HIV conversion by inhibiting cytokines. So, these are things that most clinicians never think about, never acknowledge when they put someone on long-term opiates. But these are dangerous drugs. So here's the segue into why I suddenly got a revelation of what we were dealing with long-term opiates. We know that there's physiologic hyperalgesia. When you have a tissue wound in your leg, all these agents are released. Histamine, hydrogen, bradykinin, prostaglandins, neuropeptides, leukotrienes, and they upgrade the facilitated pathways in the dorsal horn of the cord to increase pain, maybe to protect the organism, so they're more aware of it. So that's physiologic hyperalgesia. But it turns out that in the last 10 years, the scientists have known about opiate-induced hyperalgesia, and this is my aha moment. This explains why patients are getting worse every year, and nothing's changing except the drugs they're on. Because opiates actually cause more pain. It's a paradox. It's a drug opposite effect. And it does so by enhancing the facilitative pathways from the ventral medulla down into the dorsal horn of the spinal cord. This has been well worked out in animals. They've worked it out enough in heroin addicts to show that they're hyperalgesic. It's shown that in the recovery room, if you gave a patient a dose of fentanyl in the OR and compare that to someone who didn't get that dose, same surgery, they are immediately hyperalgesic. So it works very quickly. In my own experience, I tell people, if you take 3 or more Vicodin a day for more than 6 weeks, you're going to be hyperalgesic. Now that may affect people differently, but you are going to be hyperalgesic. Now we used to call that tolerance. I'm not convinced there is a tolerance. Tolerance used to be the drug didn't have lasting effects. You had to keep increasing the dose. The only difference between hyperalgesia and tolerance is as you increase the dose, tolerance pain should get better, hyperalgesia should get worse. But in reality, the only way to discriminate between those two groups is to do sophisticated pain threshold testing, which no one does in a clinical setting. So I'm not sure we can tell the difference. All I know is pains are increasing as patients are taking more and more. And they're getting more and more anxious. And they're getting more and more depressed. And if you ask them about their function, are you back at work? Are you enjoying your marriage? Et cetera, ordinarily, almost to a person, I don't hear that they're doing better. If anything, they're doing worse. They even tell me most of the time, well, it's not doing much, but it, I don't see it doing anything, but it's a pain pill, so I take it. Well, it's doing a lot of damage, we know that. So it actually shifts the pain curve to the left here. So the same stimulus causes a lot more pain. And these people become hyperalgesic. And that's typical of what I see. And see, the researchers didn't know that this was prevalent because they're not clinicians. But if you take someone on chronic opiates and you operate on them, they wake up in the recovery room like a black bear in heat. They're in pain, everything's amplified, and you've got a tiger by the tail if you didn't anticipate that, because they're hyperalgesic. And you've got a plan for that. I try to detox people before I operate on them. And actually the ones who were able to detox show some enlightened approach to what I'm saying that make them a better person to operate on anyway. Someone says, well, I'll do that afterwards. It's never going to happen usually. So what's best in chronic pain? First of all, there was a study done by the government in 2013, Agency for Healthcare Research Quality, AHRQ. They studied the world's literature in opiates and pain and gave a report December 2013. Their title was The Effectiveness and Risks of Long-Term Opioid Treatment for Chronic Pain. They concluded that the evidence suggests an increased risk of serious harms that appears to be dose-dependent. They point to a dramatic increase by 2011 of opioid overdoses. 17,000 fatal overdoses in 2011, more than heroin and crack cocaine. They point to 660,000 emergency room visits for opiate-related issues in 2010, 11. Substance abuse treatment admissions grew 6-fold between 1998 and 2009. So, we're using more opiates than everyone else, and we're paying the price. And do we have a happier population of pain patients? No. So there's not one, you'll see if you look at the literature, chronic pain equally responds to this. Well, their idea of chronic pain is a study that did a crossover at 6 weeks. That's not my definition of chronic pain. You look in the literature, there's no study over 6 months and not one over 1 year that did a comparative effectiveness study or an RCT of opiates. Until they do that, we shouldn't be giving patients opiates for chronic pain, with few exceptions. And I'm not saying there aren't few. So the most successful drugs modify the neurochemistry of the dorsal root ganglion. The medicines like the tricyclics, clonidine, which is an alpha-2 agonist, midazolam, which is a benzo, baclofen, calcium channel blockers, NMD antagonists like ketamine, to some extent thus far, Buford rather. What's this touchy-feely cognitive retraining mind-body medicine? The neurosurgeon talking about this? But actually, it's been right up there at the top of my list of what I talk to patients about when they have chronic pain. I just did it with this woman in my office who had a year of chronic pain. I gave her a book to read. I told her this was real pain. It's not telling her she's crazy. It's as real as if she had her toe cut off, but it's coming from a different place than she expected. Now we have science to back up what Dr. Sarno, a physiatrist at the Rusk Institute in New York, thought about in 1991 when he wrote his book, Healing Back Pain. I'm not saying check your brain at the door. We always should look for sources of chronic pain, treatable sources. And it's not only occasionally that I see a patient who has chronic pain that has some overlooked problem that is easily manageable. I saw a woman 3 days ago with chronic low back, right hip, and leg pain that has a scoliosis and chronic nerve compression. She's weak in her leg, and it's a pretty straightforward problem. It's anatomic. It's just been ignored. She's had pain management up the wazoo. Nothing's worked. She's had physical therapy. She needs a small surgery. So never look away from etiology, but realize that we're not omniscient and we don't walk on water. I left my water walking cane at home. So we live in a world in the United States where technology reigns supreme. That's how we spend more than anyone else on the planet. We don't have to go far to look for spine surgeons who want to operate on basically anything. And I'm not casting aspersions on the Laser Institute, but they're prominently displayed on most internet searches. We tend to over-medicate, and that includes opiates and antidepressants and benzos and dangerous drugs. We tend to over-operate on patients who should never have had one operation, much less three. So go back to square one before the operation, take your psychosocial history, get a feel for the patient, learn about other ways to treat patients. A lot of doctors said this was all hocus pocus, and it had no basis in fact, no science. We'll tell that to Howard Stern, the shock jock, radio show personality, who was disabled with back pain and was cured by John Sarno. Tell that to John Stossel, who's now at Fox but was in 2020 with Barbara Walters, disabled by back pain, now cured. They just read this book. Howard Stern went to the program. He dedicated his last book to John Sarno. It does work for some people, however you're guessing it might work, but I think we know it does work, and we'll talk about that later in the talk. So Sarno's model, he was a physiatrist at a busy rehab institute in New York. He saw all these patients that were not doing well with physical therapy, injections, surgery, you name it. And he started saying, well, if the CT doesn't show the problem, if the MRI doesn't show the problem, the X-ray doesn't show the problem, what is the problem? Well, maybe it's the brain. He had that epiphany. So he began to talk to people. Surprise, surprise, he found out there was a huge amount of chronic pain and psychosocial issue with it. And if you treated the bottled up stuff in the brain, unconscious fear and anger, you started getting patients' pains going away for the first time. So John Sarno is just retired at the age of 91. David Schechter is a local resource in LA who's affiliated with USC, who's a sports medicine internist who trained under Sarno partly. And I send him patients. He just came out with a book of his own. So if you need a complicated mind-body chronic pain problem treated, then I would probably send it to him on the West Coast. And I would read these books that I have. They're easy to read. They're for patients, but they do make sense if you're an experienced clinician and you've seen a few patients on the way. Mind-body medicine has become quite fashionable in the last 5 years to talk about it. Therapeutic touch, meditation. What is this? How does it work? Is it real? So here's where we segue into some of the science. Okay? So an MRI of the brain anatomy works on the basis of looking at hydrogen ions that are linked to water molecules and getting a radio frequency signal out of that, reconstructing the anatomy. Functional MRI looks at the ratio between deoxy and oxyhemoglobin and uses that as a surrogate for brain blood flow, metabolism, local brain function. And it turns out that fMRI, functional brain MRI, has created some revolutionary changes in our concepts. They took a group of 44 people with acute onset low back pain at Northwestern and did fMRI on them at day 1. They followed them for a year. Some subset of those developed chronic pain. They went back and looked at all their images and developed an algorithm that predicted who on the first day would develop the chronic pain, and that algorithm had an 85% tested efficacy, which is much better than us looking at an MRI. And it's probably better, it's equal to what we could have done with an experienced clinician looking for all the risk factors. So what's fMRI look like? Well, in this view, you see green areas were activated when patients were presented things visually and asked to remember them. So they're the association parietal areas and occipital parietal areas. Red areas were active when they remembered information that was presented orally, so that you wouldn't be surprised that the temporal lobe lights up more than other places. And the yellow areas were active for both types. They're third degree association areas. So what happens in pain? There have been some studies out of Stanford and Northwestern that are particularly illuminating. It turns out that chronic pain patients, their emotional centers, which shouldn't really be that activated with acute pain, are turned on all the time. In fact, some studies suggest there's cell death. The brain areas become thinner. The cells are actually dying. One study from Stanford suggested if the pain was successfully treated, these areas started to thicken, indicating some regenerative capacity. So this is all, we don't know enough yet to say definitively. But there's a high correlation between chronic pain and the emotional centers of our brain being turned on, which correlates with the histories we take. And so it opens up a door that we never knew could be, that we can actually document real time. Is this pain? We may be able to grade pain, or what's pain behavior anyway, by looking at a functional MRI much more accurately than talking to a patient.
Hi. I'm going to ask you to raise your arms and wave back just the way I am, kind of a royal wave. You can mimic what you can see. You can program the hundreds of muscles in your arm. Soon, you'll be able to look inside your brain and control the hundreds of brain areas that you see there. I'm going to tell you about that technology. People have wanted to look inside the human mind, the human brain, for thousands of years. Well, coming out of the research labs just now for our generation is the possibility to do that. People envision this as being very difficult. You had to take a spaceship, shrink it down, inject it into the bloodstream. It was terribly dangerous. You could be attacked by white blood cells in the arteries. But now we have a real technology to do this. We're going to fly into my colleague Peter's brain. We're going to do it non-invasively using MRI. We don't have to inject anything. We don't need radiation. We will be able to fly into the anatomy of Peter's brain, literally fly into his body, but more importantly, we can look at his mind. When Peter moves his arm, that yellow spot you see there is the interface to the functioning of Peter's mind taking place. Now, you've seen before that with electrodes you can control robotic arms, that brain imaging and scanners can show you the insides of brains. What's new is that process has typically taken days or months of analysis. We've collapsed that through technology to milliseconds, and that allows us to let Peter look at his brain in real time as he's inside the scanner. He can look at these 65,000 points of activation per second. If he can see this pattern in his own brain, he can learn how to control it. There have been 3 ways to try to impact the brain: the therapist's couch, pills, and the knife. This is a 4th alternative that you are soon going to have. We all know that as we form thoughts, they form deep channels in our minds and in our brains. Chronic pain is an example. If you burn yourself, you pull your hand away. But if you're still in pain in 6 months or 6 years' time, it's because these circuits are producing pain that's no longer helping you. If we can look at the activation in the brain that's producing the pain, we can form 3D models and watch in real time the brain process information, and then we can select the areas that produce the pain. So put your arms back up and flex your bicep. Now imagine that you will soon be able to look inside your brain and select brain areas to do that same thing. What you're seeing here is we've selected the pathways in the brain of a chronic pain patient. This may shock you, but we're literally reading this person's brain in real time. They're watching their own brain activation, and they're controlling the pathway that produces their pain. They are learning to flex this system that releases their own endogenous opiates. As they do it, in the upper left is a display that's yoked to their brain activation of their own pain being controlled. When they control their brain, they can control their pain. This is an investigational technology, but in clinical trials, we're seeing a 44 to 64% decrease in chronic pain patients. This is not the matrix. You can only do this to yourself. You take control. I've seen inside my brain. You will too soon. When you do, what do you want to control? You will be able to look at all the aspects that make you yourself, all your experiences. These are some of the areas that we're working on today that I don't have time to go into in detail, but I want to leave with you the big question. We are the first generation that's going to be able to enter into, using this technology, the human mind and brain. Where will we take it?
So that's a little bit embellished to sell stock, probably, but I do think it is intriguing, and it does show that just like the yogi that can control their heart rate and their respiratory rate, we might be able to control some of the things like chronic pain in these sorts of devices in a lot better way than with opiates given externally. So what does the evidence-based medicine suggest we do to treat chronic pain? First of all, I would avoid opiates. They simply don't work, or they haven't been proven to work, and we know they have a huge number of risks. Risks of hyperalgesia, risks of all those things discussed. Low T, low cortisol, lowered immune function, et cetera, et cetera. Now, obviously, you can't always avoid opiates, so I sometimes will give low-dose opiates if patients don't escalate the dose, and they seem to think they help them. I think it's probably placebo, but if they're taking 2 or 3 Vicodin a day for several years, I'm not going to split hairs. I'm not that worried about it. It's the patient who's going from 3 to 6 to 8 to Percocet to methadone or something like that I worry about. You could even make the argument that cancer pain shouldn't be treated as quickly with high-dose opiates as it has been. Because if you've been around as long as I have, you'll see that most of these patients end their days on the oncology floor getting IV drips because their pain can't be managed. And they can't be managed because they're all hyperalgesic. So we think we've done some good for them, but we've really made their pain much worse, much more quickly. That would be my argument. But I'm way swimming upstream on that right now. But we need science. Treat the comorbidities. I think Joe Frawley would tell you as well as I that you need to treat the coexistent depression, the anxiety, that what he's noticed is almost a PTSD type syndrome in many of these pain patients. They're all wrestling with tremendous anxiety and stress and bad life experiences, and he equates it to PTSD, and I think he's right. It takes a clinic to do that. We can't do it as an isolated practitioner. Favored treatments involving therapeutic touching, chiropractics. It's not invasive, it's not that expensive when not overdone. PT, massage. I'm not opposed to any of these things because they all seem to help on some level and they're innocent. NSAIDs, they can help some people, but a relatively small percent, and they have their risks long term with maybe an increase in coronary disease frequency and certainly GI issues, renal issues. gabapentin, Lyrica, Elavil, Trazodone, Clonidine, Lidoderm. We've used these drugs. We probably haven't used them in combination too much, but they're all relatively benign when monitored. They don't have the same risk factors as opiates do, and in some ways you're not growing a monster, which I think opiates do. And I go back to my favorite physician, to paraphrase Sir William Osler, who said, it's better to, I think he said, it's much better to know what sort of patient has a disease than what sort of disease a patient has. Well, I paraphrased him. It's much better to treat the patient who has the pain rather than the pain scale. And finally, to quote Dr. Mackey, strain and pain lies mainly in the brain. So that's it.